Hello viewer, thanks for joining Hollywood Dog Show today. This is our first show live from Los Angeles and it's beautiful outside. We'd like to welcome all of you who are watching this program, and you will definitely enjoy the show and the content and the guests of this show. It's a beautiful day here in Los Angeles and I'm excited to bring you our guests actually. We wanted to start this program a few months ago, like February or in March, but due to the COVID problem, we couldn't start it online. So that's why we decided to let's go to a social media platform and then see exactly, how we can start back from the studio. The main reason for this program is just to invite the uniquely trained physician who have a specialized training in special diseases, like some people who are specialized in corona or the COVID, and some people are specialized in pancreatic cancer, some people are specialized in the diagnostic radiology. So but definitely like a specialized field in the pancreatic cancer. But you will learn a lot of new feature, you will learn a lot of innovative thing, you will learn a lot of unique feature in this program. So welcome in my show. And today actually in our show, we have one of the very well-known physician. His name is Dr. Victor Scarmaro. He is a physician and he is also the entrepreneur and he is also a radiologist from New York City. Let me tell you about him. Who is Dr. Scarmaro? Dr. Scarmaro actually, he graduated from Georgetown University School of Medicine. He did his MBA from Hofstra University in New York. He did his internship from Washington Hospital Center, and also he did his residency from the North Shore University Hospital. He is a fellowship trained in GI from University of Pennsylvania Hospital. He's the author and published several papers in peer-reviewed journal and also presented in several meetings. Previously, he served as the Chief Medical Officer and also the Chairman of Radiology at the major teaching hospital in New York. And currently, he is also affiliated with the Hofstra School of Medicine in the Department of Radiology and in the leadership and also the Director of the Urgent Care Imaging. Welcome, Dr. Scarmaro. How are you?
I'm great. Thanks for having me.
So it's amazing. I'm glad. First of all, you are the first person actually who are joining my show, and today is the first day actually we are starting a Hollywood Dog Show. Hollywood Dog Show idea is just actually came from multiple people approach. So basically what we wanted to do, we wanted to bring like a unique people who know the topic, who talk about the specialty, subspecialty. So here you might not see like every physician, but we need physicians like you who are entrepreneur, who are highly trained in specialized things. So let me talk, I guess you are based in New York City, right?
Well, yeah, my practice, I'm currently with a multi-specialty group. So I'm with the radiology part, but we have surgeons, we have internists, pediatricians, so it's a diverse group. We have hundreds of offices, I guess, total for all the physicians. We have 13 imaging centers, separate imaging centers, okay, as well as 30 urgent care centers. So it's a really diverse, it's almost like a hospital system, although it's a private system.
So you are more like an academic institute as well, right? Where you are now, right?
Well, we do, we have a lot of tertiary care physicians, and we are fairly academic. We do some publishing, probably not as much as a large university center, but we are trying, even within my group of radiologists, we're trying to get a couple of presentations out for coming meetings this year.
Oh, wonderful. So I know like when the thing started, like the crazy thing, I know the entire world is going through the dark days. But when the thing started, the New York, exactly the region, hit very badly. Initially, everybody was like scared even going to New York. Nobody wanted to go. So how do you describe like, definitely I have like I tried, to gather the information, and I mean, I have a lot of questions which I wanted to ask you. So what do you see like in terms of the COVID? What's going on? What is happening in New York?
So it was very scary, I guess, come February and beginning of March, and then into April. As the cases started to mount early on before they closed everything down, we were finding cases, a lot of unexpected cases would come in. And even on things like abdominal, people would come in with abdominal pain, and we would be doing a CT scan for abdominal pain, and we'd find the infiltrates at the lung bases. So once the early papers started coming out of China, actually, we distributed them to some of the radiologists, so we were familiar already with the imaging findings on both X-ray and CT. But we found it interesting that there were people who were complaining of other things. It wasn't so much lung findings always, it was other findings, and they would be getting imaging for other reasons, and we would be finding these infiltrates.
No.
Even the pediatric Kawasaki's type of disease.
Oh wow! Okay.
We had actually had a couple of cases, not full. We had one case that was fairly full blown, but we were getting a lot of the minor petechial rashes and other things that they were getting. We had actually put a WhatsApp group together of all the physicians so we could communicate during the pandemic, since offices were closed.
Okay.
And people were, getting derm consults through the WhatsApp, and there were cases where they would be asking for imaging. We would arrange for them to come on through the WhatsApp. We actually used that as a communication. So we had to be very nimble and think differently to get through. Really, our whole practice basically changed. So our urgent care centers became the focus of the in-person clinical medicine, and we telemedicine in most of the clinical positions. And for radiology now, we obviously went down a lot in volume, but we had a lot of people working remotely, and then just a few people in the centers themselves.
So you mentioned the kids also, they are getting a sort of like Kawasaki disease exactly. So how do they present? Like they come with abdominal pain, or they can still cry,
So they were getting all sorts of things, from abdominal pain, muscle aches. They were getting these rashes and swollen joints, and they were getting all sorts of funny skin issues, and they didn't know what it was at first. And then they started to put together cases of it. And actually, in the New York area, they managed to put together a whole bunch of them and published recently. But we had seen a few of them in our outpatient setting. So I think one of the interesting things that happened, they talk about the hospitals, how full they got and everything. I was surprised the amount of people that were managed as outpatients that would otherwise have been in a hospital.
Wow.
So the hospitals were above their normal capacity. They were at least at 125% at the height, and the ICUs were double what they normally were.
I can imagine. Yeah, I can imagine.
Just and we were barely managing to contain it at the height. But there were people who were being managed on oxygen from home that would otherwise have normally been hospitalized, and people were afraid to go to the hospital.
Yes, that's true. That's true. Yeah, because there was more interaction. When you go to the hospital, you see different kind of patients. That's why. I
talked to a friend of mine who was in the hospital, and he said there was one night that 40 people died.
Oh my gosh! Oh,
I don't remember ever, more than 4 or 5 people dying in one night in a large hospital.
Oh my gosh! I can imagine. Seriously, in the worst days. I mean, still we are going through the worst days. I mean, honestly speaking. So when the patient comes, you directly take the CT, or you have any other rapid testing? I mean, CT, you say like any like low dose CT, right? Any specific?
Yeah, I mean, you could, but we generally were not using it as a test, because not everybody gets the pneumonia, so it's not sensitive. It's not sensitive enough, and it's not entirely specific. There are other diseases that could look like it, but it is certainly we used it to be suggestive of COVID in the right clinical setting.
Okay.
So we really used a lot less imaging, and most of the hospitals were using a lot less imaging, only when it was going to make a difference in the prognosis of the patient. So if they were short of breath, you got a chest x-ray on them, you might get a CT, one CT. If they were getting worse, you might get another CT. But if they were staying the same or getting a little better, you really didn't image them every day or too often, because really it didn't change what you were doing for the disease.
Okay. So is there any other rapid testing you think other than the imaging people are doing over there? And how about the accuracy? How accurate? I know the imaging CT is exactly, how does it look like on CT? What do you, like, like we are at the cancer center, so we don't see many patients, but you are basically looking like those patients every day, like, so how do you define it on the CT?
So there were, sort of patchy ground glass opacities.
Okay.
They're usually bilateral, but not always. We've seen unilateral pneumonias, mostly at the lung bases, but they can be scattered throughout, and depends on how bad it got.
Okay.
Sometimes could look almost like a diffuse ARDS type of picture.
Okay. So you see this pattern in every age group, or is there any difference you see, like age group from 25 or less or more than 25? 45 or 65, sometimes, I'm just thinking,
Well, you can see it in every age group. And certainly the older patients tended to do worse, and patients with underlying diseases tended to do worse. But I was surprised, actually, that the CTs could look terrible, the x-rays could look terrible, but the patients were still being managed as outpatients in a lot of cases.
Oh, wow. Okay. So you decide the patient should go and when they completely, like they need really to breathe, they're stop breathing, or kind of like they're having difficulty in breathing. At that time, you decided the patient should go and when, correct?
Well, yeah, I mean, that was sort of a last resort because the ventilator didn't really fix the problem. It just sort of gave them time, hopefully.
Gotcha.
But sometimes they thought it would actually maybe doing some more damage. So they really tried not to. They've tried a lot of different things. They were putting patients prone as well to try to help aerate their lungs. So they would turn them on their belly while they were intubated for a time, just because it helped aerate the back portions of their lungs better. They did a lot of different things, but I was really surprised at the devastation it could do to relatively young people, even people who did not have bad enough disease that they were hospitalized. I've talked to a lot of them. It was the worst 2 weeks, and the illness where people got the bad respiratory problems that needed to be intubated happened usually after the first week. The first week, people either got better or they would have this spiral downhill with their lungs, and which they needed to go into an ICU and be ventilated.
Okay. So one more question. Since I'll tell you like more detail, and you might know, our group also trying to do another study for the COVID patient, trying to look exactly how the CT, how the patient behaved before and after treatment. So when the patient comes, you do the CT, but do you do the CT at the time of the discharge, or you like, I just wanted to see exactly how the patient look like I know the patient are getting a treatment, patient are getting a lot of medication. So after the treatment, patient, you get any CT or just you?
I think you can monitor it just with a pulse ox, just their PO2 and how much oxygen they're using. So there are plenty of patients who didn't need to be intubated but needed 4, 6, 8 liters of oxygen, and then they would get treatment, and slowly, hopefully, the oxygen would come down, and eventually they would need oxygen. A lot of people went home with oxygen just to get them out of the hospital, and then over time, hopefully, they got off.
Oh, wow.
But we didn't really repeat CTs unless people were getting worse.
Wow. Okay. So, Dr. Scarmetto, do you see any hope at this point where we are now? I'm talking about related to the imaging. You see any hope so that we can? I know there are two facts. One, the PCR testing, and the other side, we have some treatment as well. But on the other side, we have imaging. So when we are talking about the imaging, we are talking about the ground facts, right? The reality, what it is. Do you see any hope like the patient come and can be used as a screening purpose for, like I'm talking about the next few years or months? Or?
I mean, I think they did that. They ended up doing that in China because it was easier for them to get a CT than to get enough testing, rapid testing up and going. But again, it's not entirely specific and it's not entirely sensitive as well. So we don't generally use it that way. I guess if we were overwhelmed with the amount of people we needed to test, we probably could. But I mean, New York really ramped up pretty well. We're doing about 60,000 tests a day right now in New York.
Oh, wow. Okay. Dr. Scarmetto, we are lucky. We have a clinician, we have leaders like you who are treating the patient. And it's really, we are all going through a very difficult days. Lucky, this show is actually going live internationally. We are lucky to have a very good healthcare infrastructure. We are lucky to have a CT scan. We are lucky to have a good physician like you, a radiologist like you, who can do and we can testing and diagnose and do everything right away. But there are several countries, in the world, they don't even have a ventilator. They don't even have a CT testing. I'm sure, So what my point is, the entire world is going through a bad time, definitely. I hope things gets calmed down. And also, do you see any role of imaging biomarker? I mean, this is exactly, my interest also, and how many things I'm doing in Los Angeles, so related to my academic interest. Do you see any imaging biomarker discovery in future related to the COVID, like patient come, and we discover the imaging biomarker, we define, okay, this patient has a COVID or the severity of the COVID? Please.
I'm not sure we're there yet, and I think most of the time they're trying to discourage overusing the CT for these patients. because the PCR tests, I think, will get better over time. I think they're weeding out some of the worst ones, and the better ones will be able to make enough of them, hopefully within the next few months. I know they're trying to ramp up production. You know, I think that the antibody tests are also going to be ramped up and hopefully improved, because I understand a lot of them are not as accurate as they should be.
Okay.
You know, between those two tests, hopefully, you know, we'll have a better handle of the infections going forward. I mean, I think most of the areas now have gotten some contact tracing in place. There is enough social distancing that hopefully we can keep the spread slow enough the healthcare system can handle it. But I mean, right now, I think there are places like Alabama, I understand the ICUs are getting full over there. They may have a problem in the next few weeks.
Mm-hmm.
You know, some people in New York generally, most times outside, most people are wearing masks. They're trying to social distance. I will say it's more lax than it probably was a few weeks ago. The summer is here, but most of those people are lax with their smaller family group. You know, maybe a little bit extended family, and most of that has been outside. That's my experience of what I've seen happening. But then again, you know, all it takes is one protest march to possibly spread everything again. So
exactly. What do you think? Do you have any suggestion? How do you weigh lockdown versus smart lockdown or something? What do you suggest? I know New York City, they're opening. Like I heard Pennsylvania, they're opening tomorrow. Los Angeles is already open, and I heard like there are a lot of international cities. They are also opening. In fact, like the Beijing is open, right? And the Karachi is open. There are a lot of other cities actually they are open. So, but it's still it depends like what kind of like SOPs people are using. Some people, they don't use the mask and they just go outside. So what do you think? Of course, it's not a permanent solution. We cannot live in the lockdown. What do you suggest? Your 2 cents for COVID.
I mean, I think, and I don't think you can take a one-size-fits-all everywhere. So New York State, for example, is a very diverse place. So New York City is a city with, you know, during the day, up to 18 million people are in the city living and working. I think 8.5 million live in there every day. I live in the suburb Nassau County, right outside on Long Island, which is almost 2 million people by itself. Suffolk County was about 1.8 million. That's the next county over from us. Westchester is another 2 million. Northern New Jersey is another few million. So it's really dense and concentrated there. But upstate New York is very different. It's very rural, a lot of farmland. And I don't think you need to have the same measures in both places. But some measures I think you do. So I think people, you know, certainly, and so we might have been able to get away without shutting everything down if we had done more social distancing right from the start. People wore masks, tried to social distance, and stop the large gatherings. I think that'll cut the spread a big amount. So, I mean, I think those are the main things, and we'll see how it goes. It's the summertime now. Usually the flu and viruses kind of go away for a while, and now they're usually in the southern hemisphere, and that's why Brazil is really picked up, and that may be the next hot spot really that's going to take over.
Wow.
And they're really going to have a problem because they have a lot of big cities where the poor people live basically all on top of each other, and that's a recipe for spreading the virus. And we found that here in New York, the poorest neighborhoods where 8 and 10 people lived in one apartment, those, you know, they're going to spread the virus. And there were some places where you had immigrant workers that were living, you know, going to different jobs, coming back.
One more thing, like there are several cities, like you go to Santa Monica, they allow people to live outside. Basically, there are so many homeless people, they sleep outside, you know. So what are you thinking about that? I mean, this is a big issue. I'm sure New York is a big city. I mean, sure. I live there. Yeah, I know.
So it's interesting. The amount of COVID that they found in the homeless was actually lower than the general population. There was once, you know, because they started to test the homeless shelters, healthcare workers. So healthcare workers are actually lower than the general population too. So that shows you that PPE actually works. If you wash your hands, if you wear a mask, if you're careful, you know, you can lower your risk for getting the disease.
And also, I guess because of the carrier, if you're working, a lot of physicians, they and healthcare staff, they are a carrier too. I mean, I guess, and you already have like a sort of exposure.
Well, you had a lot, but they have a lower incidence overall in healthcare workers.
Okay. Well,
and that's even with the exposure.
Yeah, I hope things get better. And somebody asking several questions, and Dr. Amber Jamal, she's asking, is there any hope for the vaccine? Any answer for this?
Well, I mean, I believe there's a couple that are at least in phase 1, maybe going to phase 2. So, and they're going to try to fast track it. I do worry when they try to fast track things that, the safety and the efficacy may not be perfect. We will hope that they don't cut any corners with that, but it's hard to do what you normally would do for vaccines that take over a year usually to come to production, to try to cut it down. So we will see if they can get something up and running quicker. I mean, I think there's some cooperation across companies now because they would rather get something faster with somebody than slower by themselves. So,
Dr. Scarmelo, the flu season is coming up in a few months. What do you see there? How do you think we should handle that situation? Because it looks like they both are synergistic. I don't know, you are the expert. Tell me, please.
Well, I don't know if I'm the expert, but I would say I think because people will be social distancing, using, hopefully wearing masks, using hand sanitizer, that the incidence of flu should probably go down.
That's true. I agree.
I hope that people will get the vaccine. I always get the vaccine. But, I think that the same precautions that we take for COVID-19 will help us with the flu. So I think overall, I think hopefully it will be a light flu year because we're trying to protect from COVID-19.
I hope so. Do you think is there any link with the oncology patient, like people who are diagnosed with the cancer, like pancreatic cancer? I really wanted to ask you a few more questions regarding to the pancreatic cancer. I know you're very high specialized, and I have a lot of questions, but I know you don't have enough time. But I definitely wanted to ask you questions related to the pancreatic cancer. But before I ask this, I want to know: do you think is there any link with the oncology patient? Because we are at the cancer center, we see a lot of course, 100% oncology patients. So what do you think? Is there any link with the COVID and oncology, or if those patients? Because when you're talking about the COVID, that means we are talking about low immune. We are talking about the inflammatory effect, right? Like interleukin-1 or 6 or whatever. That's where the treatment are working. People are working on the treatment and also the vaccine. So one of my question is: do you think the people who have a cancer, they have a high chances to get COVID, or the COVID people kind of aggravating something?
Well, I think they're certainly at higher risk, and they may have a higher mortality risk because their immune system is not going to be able to mount a response as easily to the virus. So I think that's always that's always going to be a risk when you're a cancer patient for any disease. If they're immunocompromised at the time, even something like cytomegalovirus or any other viruses, flu even can certainly kill a cancer patient if they catch it at the wrong time.
Okay. So how about since now we are on the oncology topic, I wanted to ask you something about the pancreatic cancer. There's a lot of work going on pancreatic. We have lost so many very good people, like Steve Jobs. He died because of the pancreatic cancer. And also there are so many other people who are dying because of pancreatic cancer. And the treatment is on, yes, we do have a treatment. How do you see the role of the imaging in the pancreatic cancer? I mean, I'm talking about the detection and the early detection.
Right now, imaging is mostly with CT or MRI to look for pancreatic cancer. We don't find, we can find small cancers, but the problem is that pancreatic cancers tend to have locally spread, involve the blood vessels to the gut, which make them inoperable. And even if they can be operated on, they still sometimes have microspread. My wife's cousin's husband had pancreatic cancer, was diagnosed 2 years ago, had a Whipple procedure, did pretty well afterwards, was having CTs, thought everything was great. Ended up with a bowel obstruction because of an adhesion. And they lysed the adhesion, but they found some nodules that turned out to be positive, which were not showing up on the CAT scan. They asked how that could be, and just sometimes they don't. They just blend in.
Great. Yeah.
I mean, I think that we might do better both with treatment and with follow-up, not so maybe even early detection, with some molecular imaging. So if we can find pancreatic specific cells that we can bind, the tumor cells that we can bind either chemotherapy or treatment to, and put them in the body, they can sometimes find their way. The other thing is trying to trigger our immune system to help fight the cancer. You know that in glioblastomas, for example, they have found that they were using poliovirus to help the polio vaccine to help fight the glioblastomas by injecting it in there and making an immune response that went and hit those neurocells.
Wow, interesting. Yeah.
There's some early work going with that. So there is hope. I don't think there's anything close quite yet, but there are ways that they certainly should and can be looking to fight the disease. It is a terrible disease because it has such a low 5-year survival rate.
Definitely. So mostly patients, like, there are major two kind of like adenocarcinoma and neuroendocrine. So how do you think, I'm sure like a PDAC is more than PNET, neuroendocrine one, and neuroendocrine is the worst than PDAC. So do you think, I know a lot of people that are working on the imaging biomarker, they're working on especially Dr. Van Hoff group in Phoenix, Arizona, they are actually actively working on this specific pancreatic cancer field and trying to define the early detection of the pancreatic cancer. So my question is how far we are, because at this point, early detection is nothing in pancreatic cancer. I mean, when you're talking about the patient, like let's suppose if somebody comes and they figure what they need to do for the prevention, we can simply say that 2 or 3 points, but there is no prevention kind of thing. Like, yeah, we can link it with the CA19-9 and another factor, but my question is, how do you see the role of the imaging biomarker discovery for the early detection of the pancreatic cancer? Is there any specific protocol? Like, do we have to work on it, or do we think we might need to change the modality, or we may need new modality? What do you think?
I mean, that's why I think molecular imaging is going to be the way that you're going to have to find it. Because you're going to have to find it almost at the cellular level. If you wait till it becomes even a 1 centimeter, 2 centimeter tumor with pancreatic cancer, is usually too late. So you need to catch it almost when, you'd have to almost catch it on a blood test, like a PSA, that you catch it with a little bit of a rise and then look for it very closely. Even like sometimes where we do splenic vein sampling to look for the pancreatic secretions that, for tumors that are the neuroendocrine tumors. So when you really can't isolate them, you can do sampling to see where in the pancreas it is, because you know that you have the neuroendocrine problem, but you can't find the tumor. We don't do it very often, and, when the interventional radiologists do that, but it is something that can be done. So we don't know yet where the answer is going to be. There's always going to be somebody working on something new, but my guess it's going to be molecular imaging that's going to end up being the for diagnosis and for treatment. So we'll hook it up with some sort of 4-deoxyglucose and run it through PET, or we will end up figuring out some other way to image it, and then use it for treatment too. Put it either to chemotherapy or radiation or whatever we need to treat it.
I know the PET MR is kind of like a hot topic these days. What do you think?
To me, I thought it was, does it have some utility? What you're really looking to do with a PET CT or a PET MR is look for your areas that light up and then find them anatomically. I didn't find much. To me, the spatial resolution on the CT is better than the MR in general. You spend less time in the machine. It's much longer in the machine for the MR, because you're basically still doing 2 separate tests. I'm not sure which cancers it's proven to be better yet. I don't know if it has in any proven to be better. It's proven useful in some, but PET CT really works pretty well in them. The biggest hurdle has been the insurance companies don't want to, reimburse for it, because it's more money even than a PET scan.
Exactly. That's true. That's right. It's pretty costly. That's true. In compared to the CT, PET CT, definitely, there's no doubt. Dr. Scalmaro, I really have like a lot of more questions, but I know you told me like 30 minutes might be enough, and you're too busy, and I can understand like
I have spoke to some of my colleagues and they know exactly how busy your schedule is. But let me ask you one final question. Back to the COVID topic, and seriously, the entire world is watching. As you know, we have a lot of facility, but there are a lot of other people, they don't have a facility. They wanted to know, some cities are opening, but some cities don't. Some people, they are using the mask. Some people, they are not using the mask. Some people, they have economical crisis. Some people, they don't. Some people want to go to the hospital. Some people are scared. Some people, they have some government restriction, and some people, they scared to go under this restriction. Concluding everything, please tell me your final word. What do you suggest the entire world? What they should do if they see some kind of like a COVID symptom? What should be the best strategy based on their ground facts, actually?
Well, I mean, this is what we would do in New York, and I think you should do it anywhere, whether you're in deserts of Africa or rainforest, it doesn't matter. You start to get the symptoms and you can manage at home, separate from everybody, try to keep yourself fed and hydrated, and, hopefully you get better in a week or two. And if you're under 50, you should. If you're over 70, even then you should. Most of those people will recover fairly nicely. And most of the time you don't need more than just some medication to deal with the headaches and the high fevers. Although there's some people say you should let it be a little bit high. Don't let it be too high. But, if you start to get really sick, the problem with the COVID is around 7 to 10 days, you can take a very quick downhill. People were dying at home because they waited too long. Mm-hmm. They never even made it to the emergency room. They were okay, and then they just got trouble breathing and never even made it in. Okay. So don't wait too long. So if you're really starting to get worse, especially around a week later, then you should try to seek medical attention. And it depends on where you are and what medical attention you can get. But most people don't need a ventilator, and most people who get on a ventilator don't get off. The majority don't.
Okay.
So, getting a ventilator isn't necessarily going to save you, but it will save some people. And they're getting better at treating people with the ventilators. I think they've learned a lot over time, sharing information with each other.
Perfect.
But hopefully California stays good and you stay healthy.
Okay, yeah. And Dr. Carmelo, really, thank you so much. You are the one who did the inauguration of my show. Actually, you are the first person in the show. Because definitely I wanted to invite you, but we have a lot more guests actually are coming. It's like a bi-weekly program. And again, I would like to thanks for your time, and really highly appreciate your suggestion, and really highly appreciate your advices. Actually, it is very important to learn about the imaging, because a lot of people, they have a question, they don't understand exactly why they need to do the imaging. Actually, what is the importance of the imaging? Thank you so much, Dr. Scalmedo, and I appreciate your time, and you have a wonderful evening. Thank you.
Thank you very much.
Bye-bye.
Thanks for having me.
Hello, we are back. So Dr. Scalmedo was here, and he was talking about all the COVID and the pancreatic related issues. It is very important to understand exactly how the COVID behaves and what exactly do we need to do when the symptoms come. Definitely, social distancing is the big thing. We have to do it. And also there are some specific testing. I know the people, they are not going to the hospital. I mean, I would suggest, if they really, as Dr. Scalmedo suggested, we definitely need to follow the protocol, what needs to be done, and please stay at home if you can. I mean, if you want to do the grocery or something, then go. Otherwise, it's better to stay home. And also, you will see more guests in my program starting from next week. We have a next guest, Dr. Harris. Actually, he's from Los Angeles. You will see a lot of new folks in our show. At this point, we are doing this show online through social media, but definitely will come back from the studio. Please stay tuned and keep watching my program. If you have any suggestions, email me or text me or message me, or keep checking our website, and hopefully we'll talk to you next week. Thank you so much. Bye-bye.